Hello all, I'm Dr. Shweta Santalia. You all know me. I'm the founder and mentor at MRCOG. Today we are going to discuss about endometriosis and subfertility. This is the Jan 2024 talk. This topic is very, very important from exam point of view, and the earlier talk was very old. So yes, there is new information and they can always ask you question from this talk. So it's important that you go through it and remember the important points and important changes to solve that easily in the exam. Those who are looking for organized preparation with MRCOG for their July attempt can join our mega course, which is a 7-month course including free crash course. The good news is that it is now 40% off and you can join it £299. If you're interested, you can contact us on this number or mail. So let's start. If we talk about endometriosis, unfortunately, it's a quite complex situation and it's like a chronic disease, which is creating the similar financial burden like diabetes, rheumatoid arthritis for the young people. And it's common in young people. So it is seen in approximately 10% of the women of the reproductive age group. And if we talk about subfertility, it is seen in approximately 25 to 50%. So half to 1/4 of the women who come to the fertility clinic actually have endometriosis. So it creates a substantial amount of patient in infertility clinic. So endometriosis is a condition which is difficult to diagnose sometimes. The mild and minimal endometriosis are difficult to diagnose even with laparoscopy. So yes, you should also always keep it in your mind when you're seeing the infertility patient in your clinic that it is seen in 25 to 50% of infertile couple. Now it has a very clinical presentation. Sometimes it could be asymptomatic, no symptom at all, or it can present as dysmenorrhea. We all know it leads to severe dysmenorrhea. Dyspareunia, it could be bowel symptoms if it involves a bowel. And yes, it can present as subfertility, as we saw earlier. So it's very important that you understand the diversity of the situation. It's very clinical presentation. It's complex situation, as well as if they are looking for fertility, it's a challenging thing for the clinician. Now, if we talk about treatment option for endometriosis, because it is hormone related, the mainstay of treatment is hormonal treatment. And it will be a long-term hormonal treatment, which will have a suppressive effect on the ovary. And if the ovary is suppressed, then automatically the hormonal effect will be suppressed. So the endometrial tissue, which is outside the uterine cavity, leading to all the symptom, will be suppressed for a longer time. So all in all, your goal is to suppress the ovary, to suppress the hormonal changes in the ovary, to avoid the inflammatory changes in the tissue outside, to avoid the symptom and keep it under control. Why endometriosis lead to subfertility? This is a very important question, and it's not only a single factor, it's multiple factors which are contributing to subfertility in case of endometriosis. So we all know about dysmenorrhea and dyspareunia, and it has a significant impact on the relationship, on the society, on their social life, on they are not willing to have intercourse because of dyspareunia, and that indirectly contributes to subfertility. The other important facts are that it can lead to anatomical distortion like endometriomas, the cyst, and the relationship of tube and ovary will be altered. So anatomical as well as because of adhesion and inflammation, chronic inflammation, the anatomy will get distorted and it will affect the ovum pickup, and that will affect the fertility. It also affects the egg. It also affects the egg quality. The endometriosis can affect the egg quality because of the change in the paracrine autocrine environment, and because of that and the inflammatory environment, the egg quality will be affected because of oxidative stress. If the egg is produced, egg is good quality. If the tube is patent, tube has picked the egg and it become an embryo and it goes to the uterus, then endometrial receptivity is also affected because of the chronic inflammation. Again, there will be more inflammatory markers, there will be more inflammatory cells, and that will lead to less receptive endometrium, and that will affect the pregnancy rate and live birth rate. So these are something, every step of the fertility is affected in cases of endometriosis. First the intercourse, then the egg pickup, then the egg quality, and then the endometrial receptivity. Now, another aspect is that if the patient has endometrioma and she has undergone many pelvic surgeries, or she is having repeated surgeries, big endometriomas more than 5 centimeters size, and you're doing cystectomy, then it affects the ovarian reserve as well. So not only cystectomy, even with endometrioma, when there is big endometrioma, there will, because of the oxidative stress and because of chronic inflammation and scarring of the ovarian tissue, the egg reserve will be less. So if you do an AMH for an endometriosis patient, you will see that AMH level will be low. In paradox, they say that AFC, antral follicular count, is not much affected in cases of endometriosis, which is a good thing, but AMH will be low. So AMH is not a very good predictor of ART doses, regime, and ART success in cases of endometriosis, because it is affected due to endometriosis. So this is all the pathology and mechanism related to subfertility in cases of endometriosis patient. So as I discussed, that anatomical distortion, you all know that there will be inflammation, there will be distortion. In cases of severe endometriosis, there is always dense sedation, chocolate fluid, blebs, and the powder burn appearance, brown spots, all that is endometriosis. And if it is in severe form, it always leads to adhesion and distortion of anatomy. Tubal patency, the good news is that 2/3 of the patient, tubal patency will be there, and only up to 30% of the women will have tubal pathology, which could be in the form of either obstruction, adhesion, or hydrosalpinx. So endometriosis not always affect the tube. It's mainly seen up to 30% of the women will have tubal pathology. If you see in this talk, most of the percentage are like 1/3, because you can't remember each and every percentage when you go to exam, because there are many percentage to remember. So you should just generalize and keep in your mind, even for your clinical counseling, that what is the risk, what are the chances of things happening, to tell to your patient. So 30%, up to 30% will have the tube affected. We talked about endometriomas, that it can distort further the anatomy. Endometrioma is seen in 17 to 44% of the women with endometriosis, which will approximately again fall around 1/3. And 1/3 will have the bilateral cyst. So endometrioma, usually you must have heard that bilateral cyst, whenever you see for cystectomy, you should always suspect endometrioma, because 1/3 will be bilateral cyst. Because it is a space-occupying lesion, it suppresses the ovarian tissue, as well as the oxidative stress reaction, the chronic inflammation will affect the ovarian tissue, and it will decrease the egg reserve for the patient. When you do a surgery for endometrioma, unfortunately, nearly 30% will recur in 2 to 5 years after surgical treatment. So again, as I told you, most of the percentage are approximately 1/3. Most of these recurrence will be in the same ovary, and 8% will be in both ovaries, which will be bilateral, or 11% in the contralateral ovary. Now, whenever you have an endometrioma, you always see it as a severe disease. Yes, it is a marker of severe disease. And if we see the deep endometriosis, 50% of the women will have endometrioma. So whenever there is endometrioma, it has a significant impact on fertility, because it affects the ovarian reserve, as well as to do surgery, not to do surgery is many dilemmas you have to face, which makes the complexity even further greater for the patient. So it's an important fact to remember that endometriomas are always associated with reduced ovarian reserve, and the bigger the endometriomas, the more the surgery she has, it will further have a greater impact. What about egg and embryo? So if endometriomas are larger than 3 centimeter, you will see that there is increased number of immature oocytes. So the number of oocytes are affected, and immature oocytes are more. Their cytoplasm is affected, their mitochondria is abnormal. So it affects the oocyte significantly in cases of endometriosis. As I told you, it also affects the oocyte quality. And the degree of damage to the oocyte will be correlated with the stage of endometriosis. So the more severe the disease, more affected the oocyte quality. So not only quantity, but quality is affected. Quality is mainly affected in cases of severe endometriosis, and quantity will be affected in cases of endometrioma, which are bigger with repeated surgeries. But fortunately, there will be no difference in the quality of embryo. They say that although the oocyte quality will be affected, but embryo qualities are not affected. But at the same time, due to decreased endometrial receptivity, the pregnancy rate will be less, live birth rate will be less. So it's mainly related to endometrial receptivity rather than aneuploidy or embryo quality, because they have done certain studies with the PGD and found out that the aneuploidy risk is same. So it's not the quality of embryo, but it's the endometrial receptivity because of chronic inflammation, due to which the live birth rate and pregnancy rate is lesser in cases of endometriosis patient. Why the endometrial receptivity is low? Because there is increase in cytokines, chemokines, there is increase in aromatase expression, P450, and there is reduced progesterone sensitivity in the endometrium. Though it's not very clear evidence that it affects endometrial receptivity, but many studies have suggested that it has mainly affected the receptivity rather than embryo quality. That's why the outcome is poor. So how you're going to take fertility investigation for a patient with endometriosis? You have to do all the basic investigation of infertility, like semen analysis to rule out male factor, then ovarian factor, then tubal factor. And yes, by scanning, you can see the endometriosis, and the AMH level will tell you about ovarian reserve. So all these investigations should be done. And because of high prevalence of endometriosis in subfertile women, you should have a high index of clinical suspicion of endometriosis when you are investigating an infertile couple. Earlier, you all must be remembering, the earlier TOG used to say that laparoscopy is gold standard for endometriosis, and even the NICE guideline of endometriosis say that laparoscopy is gold standard, and if you don't see it in laparoscopy, you can take it as a negative. But at the same time, they say that sometimes, even if you don't see in laparoscopy, it could be endometriosis. So endometriosis is something you can't diagnose by any way 100%. You can't say 100% you have diagnosed it or negate it. But the new ESHRE guidelines say that laparoscopy is no longer the gold standard, and ultimately laparoscopy is an invasive test. If you are doing laparoscopy to diagnose an endometriosis, it's an invasive test, and it has a complication of 1 in 200, which can go up till 7% in complex surgeries. So yes, you shouldn't do laparoscopy just to diagnose, because there are better imaging modalities now. There are advanced imaging which can diagnose things in a better way. So current ASHRE guideline, the European guideline, says that MRI and advanced ultrasound are the first line investigation for deep endometriosis in the best hands. So if experienced clinicians are doing it, deep endometriosis can be easily diagnosed by ultrasound and MRI, and you don't have to do laparoscopy for that. And once you have diagnosed it, you have to refer them to the endometriosis specialist. Here in UK, there is endometriosis specialist. So they are specially running the clinic for that, and expert in the surgery for endometriosis. So you want to then refer them to the best of the hands. Now, regarding the classification of endometriosis, there is American Fertility Society classification. We all know about AFS classification of endometriosis, but that doesn't translate into the success rate, the pregnancy rate in cases of infertile couple. So the endometriosis fertility index is something specially designed, which is a 10-point scoring system. It is to predict the pregnancy rate in women with surgically assessed endometriosis who are attempting spontaneous conception. So you have done a surgical laparoscopy and you have found endometriosis, and then you score it, and then you are predicting the pregnancy rate post-surgical spontaneous conception. So if this fertility index is high, then it is good. If it is high, means If it is 9 to 10 means they can conceive on their own up till 80% of the time, which is good. And if the score is low, like 0 to 3, only 10% will conceive, which is very low. So obviously, if the score is very low, you will not leave them for spontaneous conception, but you will offer them IVF, because IVF is the best treatment option for fertility in case of endometriosis, where every step of fertility is affected, every step is compromised. So yes, IVF is the best treatment outcome, but at the same time, you can't offer everybody IVF. Some can conceive after surgery spontaneously also. You will give them expectant treatment for 6 months at least. So who are the one you are going to leave to go for spontaneous conception? Who are the one you will decide for IVF? According to the scoring system, you can predict that. So it is having the factor of age, how many years they are infertile. So if the age is less, it will get better point. If they are infertile for less time, better point. If they have prior pregnancy, a better point. If their LF score is high, which is the least function score, normal is the highest. So higher score will be better. AFS, American Fertility Society score, if it is less, then better. And the total score is less, AFS total score is less, is better. So all in all, if endometriosis fertility index score is higher, 9 to 10, which is good, then you will leave them for expectant management. And if the score is lower, then you will better offer them. IVF is what you can infer from this information of fertility index. So how you will manage? You will get a patient, subfertile couple you have investigated, and you have found out that they have mild endometriosis or moderate or severe or endometrioma. How to manage? So we all know that medical treatment, whatever you give for endometriosis, is for suppression of ovary, and it will be having a contraceptive effect, and they can't become pregnant with that. So medical management is complete no-no. If they're trying for fertility, you can't offer them medical management. So medical management to achieve spontaneous conception or in association with surgery, before surgery or after surgery, is not recommended in cases of subfertile couple. Post-surgically, you can give them, they say that there is evidence, according to a few studies, that post-surgically, if you give them hormonal treatment, then it will control the pain. So if you are trying to control the pain, they are not aiming for fertility after surgery, you can give them hormonal suppression in form of Mirena or in form of oral contraceptive pills or Dienogest, which is recently very favorite for endometriosis. So these all things can suppress endometriosis for a longer time, and the pain will be better if they are not aiming for fertility. But if they are aiming for fertility, you can't give them medical management. Then what to do next? Surgical management, is that the answer? Surgical management is only recommended for minimal or mild disease. If you ablate the lesion, if you do the fulguration, ablation, all these things, this will help in suppressing the inflammatory reaction and overall improvement in the fertility. That's why surgical management is recommended only for minimal or mild endometriosis. And then you can leave them for spontaneous conception. So minimal and mild endometriosis, actually nice fertility is kept under unexplained infertility category itself. So unexplained infertility, mild endometriosis, and mild male factor, they keep in same category. So in minimal, you are not very sure is it related to endometriosis, but at the same time, if you cauterize them, if you ablate them, they have seen by the studies that it improves the success rate of conception. So spontaneous conception increase. So in exam, if they ask you that minimal or mild endometriosis the women has been found of, what you're going to do, so you will do the surgical management, which is ablation. So what you will do in stage 3, stage 4, which are moderate to severe endometriosis. So 20% of the women will have this stage 3, stage 4. So are you going to do surgery for them? We saw that surgical treatment will give them relief up till a certain time, and then there is a recurrence. So the surgical excision surgery will have an effect for symptom relief up till 4 years. But will this surgery improve the fertility? That is less clear. They say that there is no randomized controlled trial which will tell that if the surgery, because there are only few patients, there are not many patients who are stage 3, stage 4. So doing a randomized controlled trial is very difficult. So there is no randomized controlled trial, but different studies, the observational studies or prospective studies have shown that the benefit of surgery is less clear for this stage. So you shouldn't recommend surgery for them, but you can offer them IVF, because IVF, as I told you, has a better success rate because every step will be under control. So in one study, they have found that if you have done the surgery with or without bowel involvement, if you have done the excision, it has reported the pregnancy rate of without bowel involvement, it will be with bowel involvement further less, and without bowel involvement better. So without bowel involvement, it will be approximately 50%, and with involvement, 20 to 30%. At the same time, they told that if you look for spontaneous conception, it will be 1 in 4. If you treat a rectovaginal endometriosis, either treating or not treating is not going to make any difference. So different studies have come out with the different outcomes. So it's better that you remember that benefit of surgery is less clear in cases of stage 3 and stage 4. So ideally, you shouldn't recommend surgery for them if they're aiming for fertility, but you can offer them IVF. So you can counsel them that it does not definitely improve the fertility, but if you have symptoms, so for your symptom relief, we can do the surgery, but we can't say that it will definitely improve your fertility, but because of the less clear evidence, but it might improve, might not improve, but symptom will definitely improve. So somebody who is coming with severe pain every month, they are having severe pain for 3 days, 5 days, or whatever, their quality of life is getting affected, then you have to treat them. Then you can do surgery for symptoms of endometriosis, not for fertility, and you will inform that the benefit for fertility is less clear. So what you will do about endometrioma? This is always the exam favorite question, that 4 centimeter size endometrioma, 3 centimeter size endometrioma, what to do? So any women, if they come with endometrioma and subfertility, you have done laparoscopy for subfertility, you have done scanning, you are suspecting endometrioma, you went in laparoscopy, you have seen an endometrioma, what you're going to do? You have 3 options. Either you aspirate the cyst, you fulgurate the cyst, or you do the cystectomy. So the recent S-ray report says that you should do cystectomy, which will improve the fertility rate compared to aspiration, ablation, or just leave it alone. So cystectomy is what you're going to recommend in cases of endometrioma if you are aiming to avoid the recurrence. It will reduce the recurrence. That's why cystectomy will be helpful for the women if she's aiming for fertility. But at the same time, they have mentioned in the talk about 3-stage excision, especially for the women who have very big cysts, more than 5 centimeter, bilateral, previous surgeries. So already the ovarian reserve is compromised. So what they say in 3-stage, first you drain the cyst, then you come out of theater, give her GnRH agonist, then you do repeat laparoscopy to excise the cyst capsule. So what will happen by that is you will not affect the ovarian reserve that much. Whenever you do a cystectomy, you affect the ovarian reserve. You decrease the ovarian reserve. You remove some of the ovarian tissue, right? With the cyst wall, on the surface of the cyst wall. So you lose normal healthy ovarian tissue, normal healthy ovarian follicles. So the reserve become less. So this 3-stage excision is going to help you in doing less damage to the ovary, less damage to the reserve. So first drain it, then come out, give the GnRH for 3 months. Though they have not mentioned 3 months, but usually GnRH for downregulation can be given for 1 month or 3 months. Then repeat laparoscopy to excise the cyst wall. That way you will avoid the recurrence and you will have least impact on the ovarian reserve as well. So this is something new. 3-stage excision is something new they have mentioned in the talk, as well as they have mentioned that premature ovarian insufficiency, POF, will be seen with bilateral cystectomy in 2.4% of the cases. So this is a very important figure that when you counsel the patient, you have to tell that you have bilateral cyst. We are going to remove the cyst, and if you remove that, there is a chance of POF, which will be 2.4%. Whenever you're removing a large endometrium, a large ovarian cyst, always you have to counsel about losing the ovary sometime, as well as the effect on the ovarian reserve if they are aiming for fertility. Now, assisted conception, as I told you, this is the best form of treatment to offer to an endometriosis patient. Minimal and mild diseases you can achieve by just simple surgical methods like ablation and all. And also, if they are not able to conceive, you can offer them hyperstimulation with IUI. So this is something is new. IUI with ovarian stimulation can be a treatment option. They have clearly mentioned for mild and minimal disease, not for stage 3, 4 or endometrioma, but mild and minimal endometriosis, which is kept in a category of unexplained infertility in NICE fertility guideline, can be treated with IUI with ovarian stimulation. So you can choose that in exam. If they give you mild minimal endometriosis, not able to conceive for 2 years, you can choose IUI with ovarian stimulation as a treatment option rather than IVF because it is cheaper if all other factors are normal. So this is a condition. Ovarian reserve is normal, maternal age is fine, less than 35, patent tube, semen quality is good. Then you can try a few IUIs with ovarian stimulation for a woman before offering them ART because IVF is quite costly, right? But for moderate or severe disease, in that cases, the number of eggs collected are low, the live birth rate, pregnancy rate is low. So you have to do the IVF, but at the same time counsel the women about the effect of endometriosis on the IVF. On the contradictory, IVF doesn't have an effect on progression of the disease. Though IVF is also you give hormone control stimulation, but they say in talk that it doesn't increase the recurrence, it doesn't increase the pain, it doesn't increase the size of endometrioma. So IVF has no impact on the endometriosis disease progress as such, which is a good news. But at the same time, endometriosis itself has done enough damage and that affect the IVF success rate. In cases of endometrioma, they say that if there is endometrioma, the number of egg retrieve will be less because we are keep discussing that endometrioma affect the ovarian reserve. So if ovarian reserve is affected, obviously oocyte retrieve will be less, which will be reflected more by the AMH will be falling more compared to AFC is what they say. But fortunately, the pregnancy rate and live birth rate are not affected in cases of endometriomas, which is good. So if we summarize the treatment of endometriosis, minimal and mild medical therapy anyways is no, except in cases of endometrioma where Dynogest can lead to suppression and it will have a less impact on AMH. So nowadays Dynogest is emerging as a good drug. So Dynogest can be given in cases of endometrioma. Otherwise, there is no role of medical treatment if they are aiming for pregnancy. Surgery for mild minimal, you can try surgery and it will increase the natural conception. But in moderate and severe, you will do only if the woman is symptomatic or if previous failed IVF. Mild minimal is not going to affect the ART rate because it is just like an unexplained infertility. But moderate and severe reduces the number of egg retrieve, reduces egg quality, reduces live birth, reduces pregnancy rate. So all the things are affected. While fortunately in endometrioma, only the number of egg collected will be less. Number of egg retrieval will be less. But if you retrieve the egg, the pregnancy and live birth rate is similar. If the size of endometrioma is more than 3 centimeter, it has significantly negative effect on number of oocytes collected. So more than 30 means more than 3 centimeter size or equal to 3 centimeter size have a significant impact on egg collection. So it will only affect the egg collection. Please remember this because they keep giving you exam questions like endometrioma will affect how endometrioma will affect the IVF. So it will be only the number of egg collection, and if the egg collection won't be enough, then cancellation of cycle. That's it. It will not affect live birth rate. It will not affect pregnancy rate. So choose carefully in the single best answer. While here in moderate and severe disease, everything is affected. Number of egg collected, live birth rate, pregnancy rate, everything is affected. And as we discussed, the cystectomy will decrease the recurrence. So you should prefer cystectomy if you are doing a laparoscopy, you should prefer cystectomy. So this is all about endometrioma, how it affects and how, if we talk about endometriosis effect on in IVF cycle, the IVF cycle, as I told you, AMH and AFC are the two things which will predict your dose of gonadotropins and how to do IVF. So in cases of endometriosis, AMH is not very reliable. You have to focus on AFC and you might be needing the double dose of gonadotropins You will be retrieving less number of eggs, the quality will be affected, endometrial receptivity will be affected in an endometriosis patient. So these all things you have to counsel the women about the effect of ART in cases of endometriosis background. So that's all for with the talk. All the new information has been covered. Now this is the SBA which you can read and you can answer in the comment section. What do you think? What should be the answer for this question? So these SBAs are good practice to tell you in exam what kind of question they put and how confusing it could be with the options. This is another SBA which tells that what is the effect of cystectomy on ART. So I think it will be easier for you now because anytime you do cystectomy, there is less egg reserve, and so you will get less egg collected, and which will lead to increased cycle cancellation. So how the other aspect of endometriosis is fertility preservation. What practical advice you will give for fertility preservation? A young woman less than 35 years of age, with bilateral endometriosis more than 5 centimeters, you're going to do cystectomy. What you will tell her? What will happen to her fertility? She doesn't have a partner now. So you can always discuss about fertility preservation. Consider fertility preservation for a woman for whom you are doing in young age. They say that if less than 35, you always offer them fertility preservation. For more than 35, it's not sure. So it's individualized after 35, but less than 35, bilateral endometriosis, big cyst, you should always give them option of fertility preservation in terms of either ovarian tissue preservation, oocyte preservation, or if they have a partner, then embryo preservation is what you should offer them. You should avoid ovarian cystectomy prior to stimulation because we all know that cystectomy will decrease the egg reserve. So I do the ovarian stimulation, collect the egg, and then only do the cystectomy. But you have to do the cystectomy before stimulation or before IVF if there is pain symptom, if there is difficulty in access, or if it is previous failed IVF with symptom. Any woman who is symptomatic with any problem of endometriosis, either endometrioma or severe endometriosis, you have to operate for symptom relief. You're not operating to increase fertility, but you have to operate for symptom relief. You can't leave them in pain. So symptom is the main prediction for operating before IVF. If you think that you can't access the eggs, the excess of egg collection will be difficult, then you definitely have to do it before IVF. Or if previous failed IVF, then you can do before the next IVF. So these are the 3 indications for doing cystectomy prior to stimulation. So size is no more the criteria to do the cystectomy before stimulation. Earlier, they used to say that more than 4 centimeters you have to remove, but it's not like that now. They say that more than 3 centimeters has significant impact on number of oocyte retrieve. But regarding the management, they say that you have to do cystectomy only if there is symptom, severe pain, difficult to access the ovary for egg retrieval, or previous failed IVF and symptom. So these are the 3 indications to do cystectomy prior to IVF. Consider fertility preservation for women who require surgery for stage 3 and 4 disease. Young women less than 35, you should always give them option of fertility preservation. And following surgery, if they are young, following surgery, they are not aiming for pregnancy now, they have no partner or whatever, then you can continue the medical suppression until they are ready to conceive. This is important. If you will give medical suppression, then the disease, you will avoid the disease from progressing, and that will improve their fertility chance when they want to become pregnant. So that's all for today. Thank you so much for listening. And if any doubt, you can put in the comment section and I would be happy to help. Thank you.